Hello, everyone. I'm Dr. Catherine Kennard, the Preventive Medicine Medical Advisor for the Illinois Department of Public Health. And today I am really pleased to be the moderator for and introduce you to two wonderful speakers. Our topic today is Enhancing End-of-Life Care, the Illinois Alzheimer's Disease Plan, and Practitioner Orders for Life-Sustaining Treatment, also known as POLST. I have to read this continuing medical education accreditation statement. The Illinois Department of Public Health Medical Services Division is authorized to offer formal continuing medical education programs to Illinois physicians licensed under 225 ILCS 60, the Medical Practice Act of 1987. The formal programs must comply with the criteria in subsection C3 of 68 Illinois Administrative Code, Section 1285.110, and all other criteria in this section. This course may be used for Illinois Registered Nurse relicensure in 2025. Each licensee is responsible for maintaining records of completion of continuing education and shall be prepared to produce the records if requested by IDFPR. Financial disclosures, myself, David Hale Arroyo, who is our staff on this call, and Dr. Paul Hutchison, a presenter, do not have any financial disclosures. Jessica Link, one of our presenters, does want to state that she is working on a program that is funded by CDC, and she has a slide that will discuss that a little bit further. So here's the learning objectives for today. Upon completion of the webinar, participants will understand the impact and trends of Alzheimer's disease in Illinois, become familiar with the Illinois Alzheimer's Disease Plan to reduce risk, increase early detection, prevent avoidable hospitalizations, and support caregiving. Identify patients for whom the practitioner orders for life-sustaining treatment, POLST, conversation is appropriate, and utilize best practices when using POLST in hospital and nursing facilities. Here's my information. Again, I'm the Preventive Medicine Medical Advisor for the Illinois Department of Public Health. And our first presenter will be Jessica Link, who is the Dementia Coordinator for the IDPH Office of Health Promotion, Division of Chronic Disease. She'll be speaking about the Illinois Alzheimer's Disease Plan. And then she'll be followed by Dr. Paul Hutchison, who is the Associate Professor of Medicine and Bioethics at Loyola University Medical Center. These are our upcoming topics, and we have wonderful sessions planned all the way through July, and we'll give you these slides at the end of this presentation so you can register. And with that, here's another QRL code, so you can use that, and I will cover this again at the end. There will be a CME survey or test at the end for those who want to receive credit. And we would like to remind you to sign up for Siren, because this is the way that you can get all of the important information coming from Illinois Department of Public Health about many different health topics and emergencies, as well as sign up to participate in these presentations. And then I will share this slide again at the end for those who want to take the quiz to get continuing medical education. Okay, let me stop sharing this slide and I will pull up Jessica's slides. 1 second. Try that again. Apologies, everyone. It was wanting to pull up the prior presentation. Okay. Here we are. You ready, Jessica?
I am ready. Thank you, Dr. Kennard. I am Jessica Link, sitting in the Office of Health Promotion, Division of Chronic Disease, and I am happy to be here with you today. Thank you everyone for spending your noon hour with us. So here's my disclosure and disclaimer. I serve as the program manager for the BOLD Public Health Programs to address Alzheimer's disease and related dementias, a grant awarded to IDPH by the Centers for Disease Control and Prevention. The contents of this presentation are that of myself and do not necessarily represent the official views of, nor an endorsement by CDC and HHS or the US government. A couple of other notes before I get started. There are many references and resources that are hyperlinked directly on these slides that you will receive. And they are also included on the last two slides of the PowerPoint, which will be sent out. Next slide, please. Oh, previous slide. So Dr. Cunard went over this, but these are the two learning objectives that will be included in my portion of the presentation. I will start with some information about IDPH surveillance methods around Alzheimer's disease and related dementias, the impact of ADRD on people in Illinois living with dementia and their caregivers, an overview of the Alzheimer's disease state plan, and then finally some IDPH and state efforts in addressing brain health and dementia, including projects that are putting the state plan into action. Next slide, please. So starting off with our mission, the mission of the dementia program at IDPH really is to promote dementia capability throughout the state. This is through coordination of high quality statewide services that support the needs of all people with Alzheimer's disease and related dementias, their families and caregivers. For more information about this, you can visit the IDPH Alzheimer's disease webpage linked in this slide. Next slide, please. All right, so we will start out with IDPH surveillance. So currently our surveillance of dementia is primarily through the Illinois Behavioral Risk Factor Surveillance System, otherwise known as BRFIS. This is a CDC-sponsored survey system. It is a telephone, both landline and cell phone survey of non-institutionalized adults 18 years and older. There are questions on the BRFIS surveys about health status, behaviors, and demographics. Data is available statewide and for Chicago, suburban Cook County, collar counties, rural counties, and urban counties. So the two surveys that I will mention are the Illinois statewide BRFIS survey and the Illinois County Behavioral Risk Factor Survey, which is conducted for individual counties, and it employs the same procedures and questions as the statewide survey. It's just, it can get down to that county level. Both of these surveys have collected data that are related to dementia using the subjective cognitive decline and caregiver questions, which we alternate annually. So in other words, we collect each module on an every other year basis. It is important to note that we are analyzing subjective cognitive decline, which is not the same as collecting diagnostic or EMR data. Next slide, please. So this slide here with a nice colored map shows key findings from a data analysis that we did with the Illinois County Round Survey that I just mentioned on the previous slide. Data covered the years 2015 to 2019. And the reason that we use this data set in place of data collected in 2020 from the statewide survey is because there were too many data suppression issues in 2020. Subjective cognitive decline, per defined by BRFIS, is self-reported memory problems that have been getting worse over the past year for adults aged 45 and older. So the survey goes out to everyone 45 and older who answers the calls, of course. So what we found when analyzing this data is that the subjective cognitive decline prevalence between those years was 9.1%, or an estimated 460,000 people who were self-reporting cognitive decline. We found that cognitive decline is significantly higher for non-Hispanic Blacks at 17.4% compared to all other race and ethnic groups. It was significantly lower for adults with income greater than $75,000 at 3.7% compared to lower income groups. Findings in this report also highlighted the relationship of other health factors, including living with a disability, living with one or more chronic diseases, frequent mental distress, physical inactivity, and having high blood pressure. So, what are the implications and action? The higher prevalence of subjective cognitive decline for the non-Hispanic Black population underscores the importance of a focus on improving health equity for Black Illinoisans around brain health and dementia. Increased attention is also needed to address comorbidities. This underscores the importance of risk reduction efforts and increasing access to care, including robust health promotion programming. And then lastly, discussing memory loss with a health professional is important. Doctors and other health professionals can help by assessing brain health, helping people manage risk factors, treating other chronic conditions that impact brain health, and making referrals to community resources if cognitive decline or dementia is present. Next slide, please. So now I will talk about our recent caregiver data. This is a nifty little infographic that we are hoping to get into your hands soon. So we will start with the definition per Burfus of a caregiver. A caregiver is someone who provides regular care or assistance to a friend or family member with a health problem or disability. So you will see on this slide some of the stats. In Illinois, 16.5% or just over 1.2 million Illinois adults are caregivers. And of note to this presentation, these are all caregivers who are given the survey, not just those caring for people with dementia. 11.9% of adults expect to become a caregiver in the future. 67.1% of caregivers are providing care to a family relative that is not a spouse or partner. 20% are providing care full-time, which is 40 hours or more a week. 7% of the care recipients do have dementia or other cognitive impairment disorders. Half of Illinois caregivers have chronic health conditions themselves, and 20% report that their mental health is not good. So implications and actions here. Many caregivers do not identify themselves as such, and that is really important to remember. Cultural factors can further influence caregivers' perception and experience of their role as well. Illinois caregivers are important and they need support. Communities, health systems, public health, social services, and other sectors can help by identifying caregivers, acknowledging to them the importance of their vital role, and supporting caregivers in managing their own health and well-being. And specific to Illinois, there is a network of caregiver resource centers throughout the state that are overseen by the Illinois Department on Aging. And you can find that link. It's really tiny on this infographic, but it's also included in the slides at the end. Next slide, please. So on this slide, you can find the links to the two reports, the two burden reports based on this data that I just reviewed. And there is a lot of information in these reports, so I encourage you to go check them out. There are data tables if you're interested in seeing the raw data, and a lot of the discussion around these implications and calls to action are in there as well. They're hyperlinked at the end of the presentation, and they're published on the IDPH Dementia webpage. Next slide, please. Okay, so another project that we are working on at IDPH to increase our data collection around dementia and brain health is the Dementia and Brain Health Needs Assessment. IDPH and the University of Illinois Chicago are conducting this needs assessment to better understand the current state of brain health and dementia services in Illinois. Currently, we're conducting a survey that will be part of this and help identify gaps and opportunities to improve support for persons living with dementia, informal and formal caregivers. The target audience is medical providers, health systems, and community-based organizations, or any other entities serving older adults, persons living with dementia, and caregivers. There is a QR code on this slide that you can scan with your camera. I will also put a link to this survey in the chat in a few minutes. And my encouragement is to please take this survey because we need the voice of providers and professionals working on the front line with people who are at risk for living with cognitive decline and those who are diagnosed with dementia, and or who are serving people with dementia and serving caregivers. We also appreciate you sharing it with other providers and organizations in your local communities. And just to clarify, this is for the provider and professional community. In this needs assessment process, we are doing other collection methods to include the voices of those with lived experience, including people with dementia, people at risk for dementia, and caregivers. The survey closes on May 5th, but I recommend that if you do share it, give a 1 to 2 week deadline, and it only takes about 5 to 10 minutes, so that's good news too. Next slide, please. All right, I'm going to shift into a little bit of information about our advisory board and then get into the state plan. So Illinois has an Alzheimer's disease advisory committee that is legislatively established. There are 17 voting members and 5 non-voting members that represent state agencies, and these are all appointed by our director. What does ADAC do? Well, we meet 2 times a year in the spring and the fall to review state programs and services, and then by consensus, recommend changes to the state's response. And this includes writing recommendations and updating recommendations in the Alzheimer's state plan. Meetings are open to the public, so there's a link on the slide where you can go see agendas, meeting dates, and minutes from prior meetings. And we do encourage you to attend because we make time in each meeting for the public to participate in the conversations about advancing efforts. Next slide, please. So here we go. This is our Alzheimer's Disease Illinois State Plan. The current plan covers the years 2023 to 2026. The original plan was established in January of 2014, and it is required to be revised every 3 years in accordance with the Alzheimer's Disease Assistance Act. The current plan was updated in 2023 and reflects new initiative goals and objectives and strategies that help strengthen dementia capability in Illinois. Although Alzheimer's disease is the most common form of dementia, the plan is intended to include all dementias, such as vascular, Lewy body, frontotemporal, and other dementias. The plan is produced by IDPH in conjunction with the Alzheimer's Disease Advisory Committee, other state agencies, and various Alzheimer's disease stakeholders. This plan is meant to guide ADRD-related efforts within the state. It should be viewed as a compass shared by all stakeholders that will give a unifying direction to their programs. Collaborative efforts among state agencies, partners, and stakeholders are vital to the coordinated approach that is needed to address ADRD and increase capability in Illinois. So what I like to say is I really don't want this plan to sit on a shelf. It is meant to be a living, breathing document. Next slide, please. So now I'm going to give you an overview of the goals and then just highlight a few of the objectives because unfortunately I don't have time to get real deep here with what's in the plan. So you'll see on this slide, our workforce and training goal is to identify and develop sector-specific training modules. And I will tell you more about this later in the presentation as we are working on this within one of our federally funded projects. Under public education and awareness, this is where public health can shine with our strengths. So this is an area that has gained a lot of momentum over the past few years. IDPH ran an early detection campaign in partnership with the Illinois Public Health Association that included campaigning, but also CHW outreach with that education. And then we have now shifted into developing a brain health campaign that's focused on risk reduction. I will tell you more about that later. Other highlights of this goal include much needed work around increasing and enhancing messaging about the importance of family caregiving and family caregiver well-being as was reflected on one of those data slides. Under service delivery, enhancing dementia care coordination and increasing effective person-centered care planning is very important under that goal, as well as identifying barriers to accessing services. And also very relevant to the session, we have both palliative and hospice objectives under this goal. And really, when you look at those in more detail, at the heart of this is educating people and increasing awareness about these very important services that will improve quality of life through the end for both the person living with dementia and the caregiver. Next slide, please. These are the last three priority area goals. Under engagement, safety, and support, this goal area includes to assure the safety and protection of people living with cognitive decline and dementia because they are at risk, even higher risk for abuse, neglect, and exploitation. We want to work on assuring that emergency preparedness and emergency response plans and systems are equipped to address the unique needs of people with dementia and their caregivers, and also work on improving access to geriatric psychiatric services that are dementia capable. Again, I have a project example for you on this work in a few minutes. And then the last two goals are on data and research. You've heard about some of IDPH's current surveillance efforts, and we are open to brainstorming other creative and innovative ways to effectively collect data around dementia burden in Illinois. In regards to our research goal, our main focus this iteration of the plan is to support the dissemination of important research findings to the field. Next slide, please. So now the fun part. Here are some of the projects that are happening that show implementation of the plan. This first project is called the Dementia Early Planning Workshop Series. This aims to provide high quality advanced care planning workshops that are also culturally tailored for specific target communities in Illinois. It directly aligns with our public education and awareness goals, specifically to promote early planning for persons living with dementia, their families and their caregivers as well. The ideal outcome for this program is to not only increase knowledge about the process for advanced care planning, but to actually link the targeted audience back to the free legal and/or case management services needed to sign and put the plans in place. So you'll see on this slide, the Center for Disability and Elder Law is a fabulous group in Chicago that is working on this project, and they are calling it the Power of Planning. So they have culturally connected programming for three populations: Black, African American, Latino, Hispanic, and LGBTQ+. The focus is on individuals with early stage dementia and their loved ones and caregivers. They're partnering with trusted community organizations to host the events. And there are workshops and programming led by one of the attorneys who is able to provide them in both English and Spanish. There's also opportunities for eligible individuals to meet with attorneys to complete their documents. And then phase 2 is coming this fall, and that will be through a partnership between CEDL and Illinois Legal Aid Online. And they will be providing comprehensive, culturally connected website information with videos, step-by-step online forms for users to create their own powers of attorney. So this is really going to expand the program throughout the state. Currently, most of the workshops are offered in Chicagoland, and I have put a contact on there for you if you'd like to reach out for more information. Next slide, please. This slide shows our IDPH General Revenue Funded Caregiver Program for underserved populations. There are 5 grantees under this program. It is multi-pronged and it is providing education, support, and community connection for caregivers. And it's culturally tailored for Black, Latino, Hispanic, Asian, and rural communities. Again, I don't have time to get into all the specifics, but if you reach out to me, I'm happy to tell you more about this program. Next slide, please. CCP, the Community Care Program. This is one of our big home and community-based waivers that hopefully many of you are familiar with. But if you're not, there's a lot of information on this slide, and the program is linked at the end of the presentation. But the objective of this waiver program is to assist older adults in maintaining their independence by providing cost-effective alternatives to delay or avoid nursing home placement. Very important for our population of people living with dementia to remain in the community as long as possible. It's administered by the Illinois Department on Aging. And again, you're going to see some information on this slide about eligibility and services offered. Next slide, please. Family caregiver funding. There is funding in Illinois. There's dedicated funding out of our Illinois Department on Aging through our area agencies on aging. You'll see some of the services provided are evidence-based assessment, that helps identify caregiver needs and then tailor interventions for caregivers. There's support services and respite care, and then there's hands-on caregiver training. You will see on this map, those are the areas for AAAs, and there's more information at the end of the presentation where you can locate your local AAA agency and contact information. Next slide. Up and coming, a caregiver portal for Illinois. This was legislatively mandated. We are in the beginning stages. I am lucky to sit on the work group for this. You'll see some of the portal features as we've identified in the early stages, but this is going to serve as a one-stop shop for caregivers. Again, caregivers of all types throughout the state, and it should be providing easily accessible, user-friendly access to resources. So more to come on that.
Jessica, I just want to mention 5-minute warning.
Thank you so much. I will get there. We're almost done. Okay, so the next part of this presentation, I want to highlight federal legislation and work. So the Building Our Largest Dementia Infrastructure for Alzheimer's Act, affectionately known as BOLD, is federal legislation that was signed into law in 2018. The BOLD Reauthorization Act was passed in December of 2024. So a lot of people are excited about that this work will continue. The aim of BOLD is to create infrastructure to increase knowledge, implement effective interventions, and expand partnerships to support people living with dementia and their caregivers. BOLD directs CDC to establish Alzheimer's disease and related dementia public health centers of excellence, provide funds to support public health departments, and increase data analysis. Again, the focus very much intersects with our Illinois state plan and efforts on increasing early detection and diagnosis, reducing cognitive decline risks, preventing avoidable hospitalizations, and supporting caregiving. Next slide, please. The CDC oversees 2 major funding streams to provide funds to state, local, and tribal health departments that serve as either public centers of excellence or public health programs. On this slide, you will see the 3 current public health centers of excellence. I want to give a shout out to them. I have been honored to be able to work with each of them through the state's BOLD work. They're excellent. They are very knowledgeable and have a lot of resources. The first one is the Alzheimer's Association National Public Health Team. They're working on risk reduction. The NYU School of Medicine is working on early detection, and the University of Minnesota is working on caregiving. Next slide, please. In 2023, IDPH was awarded one of the BOLD Public Health Program grants, along with 42 other state, local, territorial, and tribal recipients. Our 5-year grant began in 2023 and will go through 2028, and our BOLD project is called the Illinois Brain Health and Dementia Project. We intend to expand and mobilize an equitable state response to ADRD, and all of the activities and strategies align with the state plan. Next slide, please, and I will finish up. I will quickly highlight 3 of our projects. The first one is the Illinois Brain Health Project, and the Illinois chapter of the Alzheimer's Association is leading this. It is a risk reduction campaign targeting modifiable healthy behaviors for brain health across the lifespan. The first year was largely planning. We are in year 2 and have identified our call to action healthy behaviors, which you will see on this slide. So much more to come on this project. Next slide, please. The ADRD training series for professionals. This is a partnership with Rush University Medical. They're developing online learning modules, and some of those do provide continuing education. There is a wide array of sectors that we are identifying. 3 of the current targeted sectors are first responders, which I know a lot of our EMS systems are on the phone or on the call, senior centers and faith-based communities as well. So these are in early development, but they will launch by the end of the year on Rush's e-learning platform, and that platform is linked on the slide. Next slide, please. Lastly, we are developing an annual rural conference under our Medical Provider and Health Systems program. This will be supplemented by ongoing engagement between annual conferences via Project ECHO through SIU Medicine. Our first conference is happening May 1st in Carterville, Illinois. And you'll see that little link called Memories Symposium, which gives you more information. Next slide. And then I will end with our IDPH Healthy Brain newsletter. This is a way that you can follow a lot of this information. There's a QR code for you. The audience is wide. There's information and resources for caregivers, providers, and people living with dementia. All the info is vetted from trusted sources, and it includes the topics listed on this slide. It is only a quarterly release, so it won't clog up your mailbox. And then Dr. Cunard, if you want to show the next two slides, those are the references and resources. I thank you so very much for the time here and hope that you find some of these resources valuable. Thanks for all you're doing for dementia and brain health. Back to you.
Thank you, Jessica. That was a wonderful presentation. And we will now move to Dr. Paul Hutchison.
Thanks, Dr. Cunard, for the introduction. Jessica, thank you for that great presentation. There are a whole bunch of pieces of that that are definitely applicable in my practice. Specifically, everything you said about making sure that these patients get set up with power of attorney for healthcare and advanced care planning documents, I think is incredibly important. I staffed an advanced directive clinic at Loyola, and the number of times that we have this very small window for patients with early dementia to get some of these documents filled out, I think it's really important to recognize that. So thank you for pointing that out. I'm going to share my screen now. Dr. Cunard, did that come through?
Yes, looks great.
Okay. All right. So I could probably talk for a couple of hours on POLST, but I'm not. But I'm going to try to condense this down into about 20 or 25 minutes. And really, I want to focus on the aspects of the POLST form and the POLST conversation that I think are going to be most applicable and most practical for the audience on this call. Couple housekeeping items first. This is a presentation, and I'm actually speaking to you on behalf of POLST Illinois, which is a committee of interested stakeholders across the state who help advocate for patients who are appropriate for the POLST form, help with legislation related to the POLST form, and also maintain Illinois' connection to the National POLST collaborative. Regarding this slide presentation, we want people to feel comfortable using the information on these slides. These slides should be considered public. We ask that you don't modify the slides, and if you'd like some slides for your own, please reach out to us at the email provided. So here are the publicly available objectives, and these, I think you have probably seen these, but what I want to also make very clear is that my main objective here is to demystify the POLST form, to explain some of the nuances that are in the POLST form and in the POLST conversation, and then make sure that the audience on this call would feel comfortable having a POLST conversation with a patient, and that's really what I'm aiming for. I'm going to really quickly, I think I've just sent a link in the chat. This link is for the Illinois POLST form. So if you want to go ahead and click on that link and have that form pulled up on your screen as I'm going through things, that's one resource. Don't feel like you have to, though. I can get through this and you'll understand what's going on without using that link. So let's first talk about using the POLST appropriately, and probably equally as important, what is the POLST form? So POLST in Illinois stands for Practitioner Orders for Life-Sustaining Treatment. You may have heard other states have forms called MOST, which is a medical orders for the scope of treatment, or POST, physician orders for scope of treatment. In Illinois, we use the acronym POLST, and importantly, it is not physician, it is practitioner. And I'll explain why that is in a second. The point of the POLST form is to help patients get goal concordant care. Now, I can't emphasize that enough. We have a lot of documents in Illinois. We have power of attorney for healthcare. We have declaration for mental health. We have the living will, and we have 5 wishes. But then we also have this POLST form, and all of them serve a specific, each of them has its own specific role in helping patients get the kind of care that they want. The point of the POLST form is to make sure that patients can specify, and doctors or practitioners more appropriately can actually put into play and execute a set of orders regarding treatments in the event of a life-threatening emergency. That's the area that POLST is most effective in addressing. It's designed to speak for patients when they cannot speak for themselves. In the event a patient is experiencing a crisis and they can make their own decisions, they get to make their own decisions regardless of whatever form is filled out. The POLST is designed to be there as an insurance policy if the patient has the emergency and is not able to speak on their own behalf. The people who can execute a POLST order are a physician who's after their first year of internship or residency, an advanced practice nurse or physician assistant. And what's important to notice about the idea of signing a POLST form is that it underlies the idea that the POLST is a medical order. And for the most part, groups of people in POLST, regardless whether it's national or different states, we don't like to group POLST in with other advanced care planning documents or advanced directives. And the reason is those advanced directives do occupy an important part or an important space in the care of patients, but the POLST is different. The POLST is an order, and the way our law is written is that the POLST orders should be followed or ought to be followed in the event a patient presents in extremis and we don't know what they would want. We are supposed to follow those orders because they are medical orders. The idea of the POLST is to ensure patient-centered care. It allows appropriate treatment if a patient deteriorates quickly. It is a way of making sure patients and their physicians or practitioners can share their preferences in a portable way. When a patient's in the hospital or a long-term care facility, these facilities generally have different ways of communicating somebody's, quote, code status. But when someone's at home, or maybe there are some care facilities where it's not entirely clear what somebody's code status might be, or really importantly, when a patient is being transferred from one care environment to another, it's really important to know what kinds of care the patient would want in the event of an emergency. And so a really important aspect of POLST is that it is portable and it follows the patient from one care environment to the next. From my perspective as an ICU doctor, the importance of POLST is when the patient shows up to the emergency room and there's no one to speak for them, or if a patient has an arrest or a respiratory emergency in the field, EMS needs to know what to do when they show up. This is the form that's on the fridge. This is the form that EMS is going to look at to determine whether or not a patient should receive CPR in the event of a cardiac arrest or whether they should be intubated in the event of respiratory failure. So if we have a whole bunch of advanced directives in Illinois and then we have this POLST form, which patients are appropriate to have a POLST conversation? So the way we like to think about this and the way we teach this is that the POLST conversation and the POLST form are intended for people of any age who are at risk of a life-threatening clinical event because of a serious life-limiting medical condition, which could include advanced frailty. Things like heart failure, metastatic cancer, advanced lung, kidney disease, frailty, or a neurodegenerative disease. So in practice, what does this look like? We call it the surprise question. If you could say to yourself when you're caring for a patient, would I be surprised if this patient were not alive in 1 to 2 years? And if you answer no, I would not be surprised, it's very possible they would be dead in that amount of time, then that's a good screening question to determine whether a POLST conversation would be appropriate for this patient. So let's look at a couple different situations. If you have a wellness visit for an adult 65 years of age or older and they have stable chronic illness, probably not appropriate for a POLST conversation. A patient who's being discharged from the hospital into hospice, very appropriate for a conversation. If you're admitting a person with increasing frailty, decreasing function, weight loss to a skilled nursing facility, good patient for a conversation. How about admitting a new long-term care resident who's in average health with some sort of stable disability? That's not a patient who necessarily would say they're at risk of dying in the next 2 years, so maybe a POLST conversation is not appropriate there. In contrast, patients with advanced serious illness who are going home or to a long-term care facility, yes. And then if a patient has had a serious change to their health status and they're coming to your clinic as outpatient follow-up, then that's another patient who you might screen positive for having a POLST discussion. So let's talk about that conversation. Similar to what we all know about informed consent, POLST is not a form, it's a process. And I know we hear that jargon a lot, but it is really important to understand POLST should not be the starting point for conversations. POLST is a decision that falls out of a value-based conversation about a patient's authentic values and preferences. It's important that a physician, APN, or PA who knows the patient, or a social worker who knows the patient, has the conversation with them, who can help explore what their values are, what their health conditions are, and how the values and health conditions might interact with each other in order to result in a thoughtful, goal-concordant decision about CPR or intubation or parenteral nutrition. So the absolute necessary precursor to a POLST form completion is a conversation about values, beliefs, goals, and priorities. As an aside, we generally suggest that if a patient has a conversation and it's very clear that they're full steam ahead and they don't see any contraindication or have no preferences against aggressive treatments in the event of an emergency, there's no need to fill a POLST form out that says full code. Since full code, CPR, intubation is the default, filling out a POLST form indicating full code has the potential to create some misunderstanding. Some people think of this patient has a POLST form and therefore they make certain assumptions about what their code status is. And as you have probably seen on the POLST form, there is an option for I want full treatments and I want to receive CPR. So in the event somebody wants the standard of care, then you don't necessarily need to fill out a POLST form. Of course, in these conversations, being extremely compassionate and sensitive to the patient's evolving health conditions, asking permission to proceed with the conversation, I think is a really, really nice technique to make sure the patient's inviting you in to have this conversation. And don't get frustrated if we're not getting decisions on a time frame that we are sometimes most comfortable with. These are hard discussions and hard decisions to make. So we need to be patient and allow patients and their loved ones to participate in thoughtful conversations and give this some time for consideration. So I do want to turn to the form now because there's some nuance here that I think is really important to dig into. There is so much to talk about in the background of each of these sections of the POLST form. There are sections here that I really like. There are sections that I don't personally like that much, but this is the form that we have. And so what I want to really do is focus on I think the areas of the form that are going to be most practical to most providers taking care of patients and who have to interpret these forms on the back end downstream. So let's look at section A of this form. And this form is divided into two main sections, section A and section B. Section A is required for a POLST form to be valid. The section A as well as the signatures are required. Everything else is optional. So if we look at section A, I want you to look at the very top line where it says orders for a patient in cardiac arrest. Follow if the patient has no pulse. So if EMS shows up to a home where a patient is unconscious on the floor, they check for a pulse. If the patient is no pulse, if they are in cardiac arrest, the instructions that they need to follow are in box A, in section A. There's only two things that a medical professional can do when someone's in cardiac arrest. You can do CPR or you don't do CPR. It's very binary. And so this is the section where a patient would need to decide which of these two options is correct for me. We're going to get back to this in about 2 minutes, but if you look in yes, CPR, attempt cardiopulmonary resuscitation, this says it requires choosing full treatment in section B. I'm going to get back to that in a minute. But for purposes of cardiac arrest, all you need to know is I'm in or I'm out. Do CPR or do not attempt CPR. Section B. This gets a little more complicated, but we have to start with the instructions. The instructions at the top are these are orders for a patient not in cardiac arrest. So EMS feels for a pulse. There's a pulse. We follow box B. These are the instructions we follow. Because the patient has a pulse, CPR is off the table. We don't do CPR on patients who have a pulse. There's another algorithm for how we approach patients with a pulse. And so in this hierarchy here, we've got 3 different treatment options. One is called full treatment, one is called selective treatment, one is called comfort focused treatment only. Full treatment says that we should do everything we can to prevent the patient from losing a pulse. That makes sense. And included in this would be utilizing intubation and mechanical ventilation, if indicated, in order to stabilize the patient and prevent a cardiac arrest. There will be some patients who do not want an intubation and use of mechanical ventilation. Those patients would be more appropriate for one of the next 2 options, one of them being selective treatment, where the goal is treating medical conditions to the best of our ability, but do not intubate or use mechanical ventilation. Things like non-invasive positive airway pressure, CPAP, BiPAP, high flow nasal oxygen, Vapotherm, OptiFlow, those things would be all appropriate for someone who wants selective treatment, as well as other forms of what we would consider to be less aggressive medical treatments, IV fluids, antibiotics, pressors, if consistent with the patient's goals. And then we have comfort-focused treatment only, which would be basically we're not going to do anything invasive to the patient. We're only going to transfer them to the hospital if their comfort needs cannot be met in their current location. This is where the best example is somebody going home on hospice. Okay. This section is also optional. And if nothing is checked in one of these boxes, we assume full treatment is the default option. Okay. So differences between sections A and B. Section A, cardiac arrest, there's no pulse. Section B, it's when pulse is detected. Section A, it's only about CPR preferences. Full code, DNR. Section B has nothing to do with CPR because the patient has a pulse. We divide the treatment options into full, selective, or comfort. Section A is required for completion for a valid form. Section B is not. Another way of looking at this, I said I was going to come back to that qualification under Section A, that if a patient wants CPR, they have to be full treatment in Section B. So that's depicted in this arrow. However, if you are DNR and you don't want CPR, you can still be any of those 3 options. So I'm going to play this out for you very briefly here, and I'm going to depict it very differently. The question for a patient up front, if we're going to have the conversation, is would you want CPR? But you're not going to put it this bluntly, obviously. You're going to go into some more detail. If a patient says they want to live and they're willing to accept the most invasive form of resuscitation we have, which is CPR, then what they're saying is, I'm all in. And if they're all in, that also means that they need to be okay with intubation. The reason they need to be okay with intubation is because the ACLS algorithm includes intubation if appropriate. And ACLS, Advanced Cardiovascular Life Support, is not an a la carte menu. It is a standardized approach to treating patients in cardiac arrest. So if somebody wants CPR in the event of an arrest, it would not make any sense if they were in box B for them to say something like, well, if I'm having a bad asthma attack or COPD exacerbation, don't intubate me. But then once I have my cardiac arrest, then it's okay to intubate me. That logically does not make a lot of sense. And so if a patient does want CPR, you're in the left side arm of this process map, that they're going to be full code for a cardiac arrest and full treatment for a pre-arrest emergency. In the event they're 95 years old, they know CPR, the outcomes would not be very good. If they had a cardiac arrest, they might say, if I arrest, I don't want CPR. However, if I do have a pneumonia and my doctors think that I need to be intubated to save my life, but potentially I could still get extubated after 5 days on the ventilator, I would be okay with that. Well, in that case, you would be no CPR in the event of a cardiac arrest in Section A, But then in section B, you would be full treatments, meaning I do want to be intubated in the event of a respiratory emergency, or that same patient may say, I also don't want to be intubated, so I want to either be selective treatment or comfort focus measures only. So how do we apply the POLST paradigm in practice? In hospitals, you are not required to complete POLST forms as a matter of documenting code status. In fact, it's relatively inappropriate to do that. Every hospital or facility, we'll talk specifically about hospitals first, they usually have their own source of truth, right? So at my facility at Loyola, we have Epic, and the code status at Epic is the code status. Now, if a patient comes in with a POLST form, we need to make sure that POLST preference still applies, but we still need to enter the code status into Epic. If there is no POLST or the patient doesn't have capacity and there's no decision maker, then obviously the patient is full code by default. And that's a presumption we make. In skilled nursing facilities cannot require POLST completion as a condition of admission. Also, a lot of patients who go to skilled nursing facilities are not appropriate for POLST conversations. The only requirement that skilled nursing facilities are under is to make sure they have a policy for how to determine and document code status. There is no requirement that POLST forms are completed, and in fact, they can't be completed as a condition of admission. For hospice, similarly, POLST is not required to elect hospice care. Most of us would recognize that being DNR is very appropriate for somebody entering hospice, but POLST cannot be required as admission to hospice. Some additional considerations. I already mentioned that it cannot be required for nursing home or admission for care. Be very careful if your institution uses different colored forms for full code and DNR. Be aware if your institution does things like that. We encourage systematic quality improvement processes to replace or update old forms. The forms were updated in 2022, and so there have been some changes, and it would be appropriate to go through and review those old forms, although old forms are still recognized by EMS. I mentioned this already, not every facility must use a POLST to document code status, but every institution must recognize a POLST form when it comes in. They cannot say, well, that's a POLST, we don't do POLST here. No, everyone is obligated to follow POLST orders. And then we obviously recommend that policies and facilities should address the different aspects of POLST, how to complete and how often to review. So what's required for a valid POLST form? The patient information, section A has to be completed, and then there needs to be 2 signatures. Either the patient and their legally authorized representative and a qualified healthcare practitioner, physician, second year or higher, PA, APN, and then obviously the data signature. Sections B, C, and D are optional. We recommend pink colored paper for visibility purposes, but that's not required. If someone has an old form and they complete a new form, the new form takes its place. Photocopies of forms are valid. Electronic versions and copies on electronic devices are also valid in 2025. Very quickly, I'm going to do 2 case examples to kind of help everybody understand how you would complete these POLST forms. So in case 1, it's a 60-year-old male, metastatic prostate cancer, previously independent in his ADLs, but now he's been in and out of the hospital. You have a goals of care conversation with him, and you learn that he recognizes that his illness is terminal, and for that reason, he doesn't want to undergo CPR in the event of a cardiac arrest. He also does not want to be intubated if he had a primary respiratory emergency. His quality of life is still acceptable to him, so he's willing to accept low burden, less invasive measures to prolong his life. So if you look at your POLST form that hopefully you have up on your other screen, this is somebody who in box A would say, in the event of a cardiac arrest, that I do not want resuscitation, so I'm DNR. And he also does not want mechanical ventilation, so he would be selective treatments in box B, Not quite comfort though, because he is willing to accept some lesser invasive therapies to maintain a quality of life. Case 2, 75-year-old male with late stage COPD, recently hospitalized, required intubation, but was able to be extubated and was discharged to your facility. You talked to the resident, you learned that they understand that if he had a cardiac arrest, the likelihood of meaningful neurologic recovery would be low, does not want CPR, but is willing to be intubated should he suffer potentially reversible conditions such as pneumonia. So in that case, looking at your POLST form, this is somebody who says no to the CPR, so box A would be no CPR, but this patient, having just been intubated and knows what that's like, is accepting again of an intubation for a COPD exacerbation or pneumonia. This is a patient who would be full treatment in box B, and that would be the appropriate set of POLST options for this patient. So we have a lot of resources through POLST Illinois at these addresses here. You can also email POLST Illinois and someone from our committee will get back to you. There's some additional links here that when you get these slides later, you can explore. And I will stop there and see if there's any questions. Thank you all.
Thank you, Dr. Hutchison. That was a wonderful presentation. We really appreciate you spending time with us today. If anyone has any questions for either of our speakers, if you could just drop them into the chat and we'll be happy to answer them. I do see one here for you, Dr. Hutchison, that says, is POLST required for admission to assisted living facilities since these differ from skilled nursing facilities? I've been told by some that they cannot admit the patient without it.
So to my knowledge, a POLST form can never be required as a condition for admission. Is that universally followed? It sounds like probably not. I think what's appropriate is that for facilities to have a conversation seems okay, but to make a patient complete a POLST form, this is not something that any patient should be required to do as a condition for admission anywhere. Conversation can be appropriate. Mandating a form completion, that's probably not something that should be happening.
Who asked the question says thank you. And then another question is, would it be helpful to have a patient's recent photo on the POLST form, particularly for persons in home hospice? I don't see a place for a photo on this form.
So that's a really good question. I haven't heard that before. So there's a lot to talk about here. First, I'll say we worked very closely with IDPH and other stakeholders to revise this form in 2022. There is no real estate for anything else on this form. I'll start by saying that. There's just not a lot of space for that. I will say that Illinois is potentially moving towards a POLST registry. And I don't know if because that'll be an electronic registry similar to organ donation, not exactly the same, but similar to. I don't know what the role would be for some other identifying information in a registry like that, but that's a very interesting suggestion, and I think something that's worth taking up as we move forward in this registry process.
We have two additional questions, but one is for you, Dr. Hutchison, on verbal consent. For POLST, verbal consent for a patient or representative to be a DNR is acceptable if they cannot sign. And verbal order is also okay per policy when the signature should be made, right? That's the way the question read.
Yeah. So if you turn your POLST form over, there's a little guidance here, and then we say find the right thing here. Let's see here. So verbal phone consent by the patient or legal representative is acceptable. Verbal phone orders are acceptable with follow-up signature by the authorized provider with the facility consistent with facility or community policy. So yes, we can do this verbally, particularly when patients can't sign themselves. On the provider side, a real attempt should be, even if there's a verbal order that occurs, every attempt should be made to get that person to sign the form at the soonest possible convenience.
One other, and then I know we're at time. People have been told to bring their POLST form to their local fire department. I guess that would be their EMS provider who would be coming. Is that important?
So I understand it's bring them with you when the ambulance is coming, or do you just show up to the fire department with your POLST form? Is that the question?
Yes. Are they told to bring the form to their fire department? I think this is very important.
Well, so I'm the son of a firefighter, and while my father was a firefighter before POLST was sort of a big deal, I'm not sure they know exactly what to do with the POLST form at the fire department, and nor do I know if they are going to keep a file of these POLST forms, just logistically how that would work. I think this gets at the registry, right? Because you don't know. I mean, they're not bringing a box of POLST forms to every call they go on. I think more importantly, have that form in your house somewhere that's visible. Have it on the fridge. When I fill out POLST forms with my patients, I make sure that it's in a visible, accessible location. I make sure that the patient knows, have a copy on your phone. More importantly, because if the patient needs their POLST form, they're not pulling out their phone at all, right? It's their loved one pulling out their phone. So make sure these forms are on the phones and on the devices of the people they live with and the people who care for them, because those are the people who are going to be in most need to show this to EMS, first responders, as well as the providers in the emergency department in the event something happens.
All right. Well, thank you very much. We had one person express concern about federal funding for the wonderful programs Jessica shared with you, and she did respond in here that at this time there's no known plans to reduce that funding. So let's keep our fingers crossed. Thank you both for wonderful, wonderful presentations that provide a lot of terrific information. And all of you who are participating, you will receive this information link to the survey and also to the CME quiz to get credit. If you want to quick put your, I hope this is showing, but if you want to just quick put your phone up over this QR code, that would be great. Otherwise, David, our wonderful administrative assistant, said that he would send you all the information. So thank you. And thanks again to our presenters, and you all have a wonderful rest of your day. You're having lots of thank yous and hearts in the chat. So thank you both. I really appreciate you coming today.